That's all right.
Hi, everybody. My name's Renza and I work at Diabetes Australia, and I'm thrilled to be back for another one of our Thursday Facebook Live Q&As. And this week I am joined by GP John Barlow, Dr. John Barlow, and we're here during Men's Health Week. So the focus for today's chat is all about men's health and diabetes, and issues that are, I guess, specific to men living with diabetes about keeping healthy. So these chats work absolutely brilliantly when they are really interactive. So we've got lots of questions, but we're hoping that the people watching will be asking questions as well. You can do that just by typing a question in the comments section of Facebook. If you've got a question that you would prefer that people didn't know that it was you asking, you can just send it as a direct message to Diabetes Australia, and one of our Diabetes Australia team then will ask that. But we're planning on being very candid and covering lots of different topics. There is no such thing as a taboo topic in any of these. But John, hello and welcome.
Thank you, Renza. How are you?
I'm very well. How are you today?
Hello.
Oh, hello. Are you there?
Connection issue?
Are we have No, I'm all okay.
Yeah, you're just a bit blurred, but I can hear you.
Good. Okay. All right. Technology is great when it works.
Exactly.
Okay. So, yes. So thanks for joining us today. Now, you're a GP. Where are you based, John?
John, correct.
Yeah. Sorry. No, where are you based?
I'm a GP in Sydney Southwest in Bankstown.
Okay. Great. Well, thank you. Well, look, let's kick off with some questions.
Sure.
It is Men's Health Week. And so one of the things that I wanted to ask was just really broadly, what are the specific health issues that men living with diabetes might want to think about, and what sort of conversations might they like to have with their GP?
Yeah, look, the thing is with men, our waiting rooms, I'm a typical GP, my waiting room's full of women. So the first step is to try to get doctors to come, or to get men to go to the doctor. Usually they've been pushed in by their significant other, whether it be their wife or partner or whatever, or the family, because they're worried about them. So from my point of view, a lot of men are overweight or obese. They don't think they are, but their family usually does. And they're very reluctant to sort of talk about this. The real issue, particularly when it comes to type 2 diabetes and even a pre-diabetic state, is when they start to have sexual dysfunction, namely erectile dysfunction. That's often the thing that will bring them to the doctor because they're worried and they want something done about it. In 2020, it's so easy to have that conversation with men. Perhaps 20 or 30 years ago, not so easy. And it's something I always bring up with all my diabetic men anyway. Because there's things that we can do about it. And I suppose in days gone past, we didn't have any specific interest or treatments that were effective in treating the condition. So we all know as GPs that erectile dysfunction, sexual dysfunction, can be an indicator that there's a vascular problem there, and very often associated with diabetes.
Yeah. So why is it, do you think, that, look, talking about sexual health for anybody can be a little bit, it's seen as a taboo subject. People might be embarrassed, which they absolutely shouldn't be. So how do you find it when you raise this topic and you say, hey, let's talk about this, if you're asking someone if they haven't, is that received well, or do men sort of start shuffling and looking at the ground?
Yeah, look, I think the embarrassment's not only with doctors, but also with patients. Some patients are reluctant to talk about it, but when you mention it can be associated with their condition and that it's not their fault. It's often not a psychological problem, although often in younger men it is. When you explain to them that's part of the disease, it's usually accepted quite well. And most men have heard of the drugs, particularly the oral drugs we use for erectile dysfunction, because they go to the pubs or clubs and they talk to their mates. And I think they probably feel better about talking to colleagues rather than their doctor about it. But they usually come to us because there's something we can do about it.
Okay, so it's
much less an embarrassing problem.
Yeah, absolutely. And someone's just commented men would rather bury their head in the sand rather than talking about it. And we know. So we need to find ways, I guess, to make...
That's not true. That's an assumption. In 2020, that's not necessarily the case. I see a lot of men. I see a lot more women. But can I say to you, no, look, in days gone past, I think that comment was true, but it's not so true today.
Yeah,
so
which is great. I mean, I think
I find if I sort of if I just sort of talk as male to male in an easy way around it, it's interesting. Some men, particularly young men, would rather go and see a female GP. I think they feel more embarrassed seeing a male GP. So it's interesting. But the older man who is having some problems, particularly when they're patients of mine and they've been patients for years, I'm more than happy to talk about it today.
That's good. George says, I will talk. Good on you, George. Yeah.
So it's not taboo.
Exactly. And I really love the way that you're normalizing this. You know, I always think, you know, you go to the GP and it's like, can we check your blood pressure? Let's check this. Let's check your cholesterol. Let's talk about sexual function. And it should just be part of, you know, every other, you know, checkup that we have when we're seeing the when we're seeing our GP.
So to give you an idea, so we had that little chat around it, and then I say, look, we need to sort of find out why. We need to do some tests. So I usually get them back, and more often than not, I'll find that common problem, pre-diabetes or impaired fasting glucose, is a big issue, and you identify problems. And when you identify problems, you can then talk about treating problems. So it's a good general health questionnaire. So whereas sexual talk used to be taboo, it no longer is, and it can often be a lead-in to a general medical check and identifying problems that need to be identified so we don't end up with complications.
Yeah, absolutely. So look, we've launched in talking about sexual health, so let's just continue that. Now, I know that erectile dysfunction is often what we talk about when we're talking about how diabetes can impact on sexual health for men, but are there other issues as well that, I mean, can we talk about, can libido be affected? Are there other things that can also be affected?
Yeah, look, there's other things, you know, like probably weight's the biggest thing with men, and that realization, you know, we often get them in. I don't believe in body mass index. Waist circumference is the way to go, and you can that's how you identify overweight patients, obese patients, and that again leads into probably not so threatening a thing if you don't want to talk about sex, looking at vascular disease and looking at chronic disease in general. So we talk about weight, then you talk about lifestyle, you know, what they're eating, are they exercising? You know, there's often they're eating the wrong things, they're not exercising. So it turns into a lengthy conversation, and sometimes you need to prioritise it and get them back for a general talk and a general medical assessment.
Yeah, absolutely. So I have been involved in some research around men's and women's sexual health for people living with men and women living with diabetes. And one of the things that we hear women say a lot is that because they're concerned about their bodies, and that could be because, you know, for people who are taking insulin, there might be scars on their bodies. If they're wearing devices on their bodies, that makes them feel a little bit nervous and reluctant and unattractive. You know, there becomes a body image issue. How does that translate for men as well?
That's interesting. That's a misnomer. It's not the insulin or the injections that causes scars on the body. It's the fact that they're probably not injecting properly. So they're getting these areas of lipohypertrophy, we call them. So that in its own right is a misnomer. But women are far more worried about their psyche and far more worried about the way they look than a lot of men are. Mind you, I just saw a young guy, was my last patient, and he's got these tiny spider veins on both his lower legs. And he said, I know I'm a bit vain, but I'd like to go and see someone about it. So I showed him my legs because I've got some veins there and they don't bother me. So it's all a matter of perception.
Of course it is. We're not going to show any veins here now. Now, look, I have a question. We have a question from Bastian, and sorry if I'm not pronouncing that right, but Bastian says, do you think that men, okay, I'm going to rephrase the question because I don't use the term non-adherence, but do you think men are more at risk of not following their insulin dosage and management plan as has been set out? Are men less likely than women to do that, and why might that be?
Look, there's no doubt about that, because men often live in a world of denial. They don't want and it's true what someone said, they bury their head in the sand. That's pretty true about illness and whatever. But can I say that that's where we need to sort of collar the help of their families and their partners and other allied health professionals when I don't have the time to spend a lot of time doing that. But can I say non-adherence to medication is across the board, male and female. But look, I think you're right. I think it's more common non-adherence to medication in men than it is to women.
Yeah. Okay. So let's move on. So I think we've answered all the questions that have come in so far, but do keep them coming. This is great to know that we've got people who are engaged and wanting to ask questions here. But let's talk. We've sort of touched a little bit there on mental health. You mentioned that sometimes things could actually be psychological. Do you think men are? And we're not. I should really just point out we're not generalising here. Of course, everybody obviously is going to be different. But do you think that there's a stigma associated with men seeking mental health support? And if so, how do we address that?
So there's generally a stigma about men seeking support in any condition, whether it be a physical or a mental condition. And, it's part of that macho male psyche. Look, you can't generalise here because every male's different. There's snags and then there's that deny it and all that sort of thing. So we're all different and it's a very personal thing. But, I find, and I've found when you're talking to men, and I've found this over the years, that you sort of come in the back door and just ask some simple questions that will give me a clue that there might be a problem there when they don't realise there is a problem. So, look, there's no doubt that men often bury their head in the sand, particularly in regards to physical and psychological illness. But if they're put in that situation where it's sort of normalised rather than sort of stigmatised, I find that that's often a lead-in and they'll often accept your help. And these days, as you know, the government's thrown a lot of money into mental health, particularly in terms of psychological therapy. So, choosing the right psychologist, whether it be a female or a male, asking them the question. So it's a matter of sort of talking to the patient and finding out what their goals are and what their needs are. And if you address all that, you often end up with a good outcome.
Yeah. So how important is it, do you think, that men, and this is probably for everybody, but let's just focus, men in particular, really develop that strong relationship with their GP or whoever their health professional is? Do you think that continuity of care issue, and also knowing that the person that they'll be seeing is the same person they saw last time and that they don't need to start from scratch, is that really important, do you think?
Look, I work in a typical family medical practice, 2 male, 2 females.
Yep.
So we often see the same patients all the time. I know a lot of practices are hurting at the moment because of COVID and decrease in numbers, particularly in medical centres.
Yes.
I repeatedly get people come to see me and say, I'm so glad I can see the one person all the time.
Yes.
That continuity of care is so important because it's all about developing a relationship. And, when you've been around for as long as I have, you can pick it coming in the door. And if you give them the time and you talk to them and sort of address the problems, that's what it's all about. This 5-minute Medicare medicine we talk about, coming in, what do you want, get it, go out. It doesn't work in 2020 for the majority of patients, particularly when it comes to chronic disease management. Sure, if you've got a cold or urinary infection or an injury, it doesn't matter who you see. It usually gets better anyway, even if you don't see a doctor. But when it comes to chronic disease management, it's so important to develop that relationship with one person or one practice where everyone has access to the record, they know what you think, and they're happy to see it. Even in our practice, there's 4 of us. The patients self-select and they come and see who they connect with. It's all about a connection. That's across the board, I think, not just in medicine, but in life. We all get on better with some people than others. It's just a natural human phenomenon, not just with men, but probably more difficult with men. Yeah.
Okay. So how often does this happen? Is this a thing that happens that you find, is that a man will come and see you and, I'm here for whatever, and then just as, you think the consultation's finished, they sneak in the real reason that they're there. The real reason that they're there may have been something that they were a little bit reluctant to talk about. And so does that mean we just go back and sit down and we'll have this conversation now? How does that work?
No, I'm smarter than that. I bring it up first, and it's almost invariably around erectile dysfunction.
Yep.
So can I say to you that you might think I'm a sexual health doctor, but I'm not. I'm a GP. But can I say it's often an embarrassing problem, whether it might be a mental health issue, it might be a sexual issue or whatever, but it's always at the end of the consultation. So for me, I treat a lot of patients with type 2 diabetes, and a lot of them are men. And I proactively bring up the problems before I just wait and sort of at the end of the consultation for them to talk about it.
Yeah.
And
I
I think we
really
need
love
to
that.
do that.
So, yeah, I think that that's so great because, you know, one of the things that we talk about, you know, is the importance of talking about, for example, for women with diabetes is pre-pregnancy planning. So even if it's years away from wanting to have a baby, you start to talk about it so that it becomes just something that seed is already planted in people's mind that, yeah, we're going to be talking about this. So that even if somebody is not experiencing erectile dysfunction, at least having the conversation so they know if that does happen, there is somebody who is going to be able to help me address that. That's really important.
Something that I'd like to touch on too, and it's becoming we know it's a global epidemic, and it's called type 2 diabetes. It's probably one of the commonest chronic disease management issues we have in 2020. Yes. We know that it's increasing. We know that there's certain populations where it's more common, particularly the indigenous, and certain populations like Polynesians, Indians, Chinese, that sort of thing. And it's very different for men than women. We do know, and there was a big study done in Glasgow years ago that showed you don't have to have so much weight gain in men to develop diabetes compared to women. Women need to, because women sort of tend to put the weight on in the right places. We're talking about the hips and thighs. Unfortunately, men put the weight on where it's bad, usually around the girth and in the liver. And of course, that's associated with fatty liver disease, pre-diabetes, and frank type 2 diabetic, frank type 2 diabetes. So, you know, men are different from women, and that's probably one of the reasons why type 2 diabetes is often more common in men, because they put the bad fat down rather than the good fat down. So it's an interesting phenomenon, but it's out there, and we need to actively look for it. As a GP, we need to look for people who are pre-diabetic, because there's no doubt if we can get onto some lifestyle changes, and they don't have to be big, that we can prevent people from going from pre-diabetes to type 2, frank type 2 diabetes. So it's a call to action to all of us as GPs in Australia.
And I think one of the things that perhaps, you know, that we hear from people with diabetes is that there's often so much stigma associated with diabetes. So because we know that there are things that the individual can do perhaps to modify what happens with their type 2 diabetes and developing it, that they feel that if they do get it, they're blamed. So how do we have conversations about, hey, let's talk about living, you know, about adopting some healthier eating habits or healthier exercise patterns without making people feel that they're being wrapped over the knuckles, and then if they do get diabetes, that no one is saying, I told you so, because that is never going to help anyone, is it?
No. So from the outset, you've got to explain to them what it is. What does it mean? What are the complications? What if I don't treat it? That sort of thing. So it's a matter of having that conversation with them. And they'll sort of say, well, you know, I'm so used to, you know, eating this, or, you know, not doing much exercise and all that. So what you do, you've got to talk to them and say, look, a small reduction in fats and sugars in your diet. You don't have to go to a dietitian. For me, it's often a portion control idea. You know, like, don't deny people what they want to eat, but say, well, why don't you halve it? And look, I know you don't exercise. Is there anything you like to do? There's nothing worse than giving people an exercise program and getting them to try and exercise when they're not going to do it because they're not interested in doing it. If you've got a mate next door, you might go walking with, 3 or 4 times a week. You used to play tennis. Would you go back to maybe joining a social group? Even just going walking with your wife, something you've never done before. Maybe it's worthwhile to reconnect with the wife or the partner and go walking. And we know that 30 minutes of intense exercise 5 times a week is very beneficial. We know that weight loss doesn't have to be huge. You see a lot of men who are 100 plus kilos. 5% of weight loss, whether it be because of dietary manipulation or exercise, can result in significant changes in terms of their vascular risk, their blood pressure, their blood sugar control. So the important thing is to say, look, set a small goal first, and once we reach that goal, we might change it. It's like when we talk about target HbA1cs as a measure of control in type 2 diabetes. We mightn't get them to the target we want, but some reduction or some improvement in control, reduction in A1C, is better than none.
Of course.
It's a thing. It's a thing called taking baby steps.
And I think that that's so important. And one of the ways that we talk about this often is that, when it comes to whatever it is, whether it be monitoring glucose or whether it be, as you said, an HbA1c, which is, for people with type 1, type 2, all sorts of diabetes, anything. If you say you need to go from 0 to 100, it's never going to happen. But hey, let's go from 0 to 5 and let's see how we go then. And that's awesome. And if we fall off the wagon, we all fall off the wagon. That's okay. We'll get back on. And look, I love this comment from George. George has got a really, really good comment where he says that he keeps good gut health, and that means all the difference to mental health. And I think that's one of the things as well. That's one of the benefits we don't necessarily talk about when we're talking about getting out and being a little bit more physically active, which might just be a walk around the block. That absolutely can do wonders for people's mental health outlook, can't it?
I do. When it comes to exercise in men, often they're feeling tired, they're overworked, they're stressed and all that. I talk about the benefits of exercise in terms of endorphins, those things that go up in your blood that make you feel better. And it's amazing when they come back, you see it. Patients come back, their blood sugar controls improve, they're doing a bit of exercise. They just generally feel better. And we know that particularly type 2 diabetes is associated with poor mental health in terms of anxiety and depression. And I think it's got to do with, if we treat it correctly and we get those endorphins up in their body, they're going to feel better. And when you show them that happens, they're often then more likely to continue. The hardest thing you can do, particularly in an elderly patient, and we know that our elderly folk, this is where the incidence of type 2 diabetes is highest. Age is the biggest risk factor, not obesity. So, but trying to get those elderly folk to change what they do, to exercise, to, change their dietary habits. It's the hardest thing we can do as a GP. That's why we take small steps.
Yeah, absolutely. Now, we've got a question from Jason. It's actually a question in two parts, but let me start with this part. How can Jason, or anybody for that matter, lower their triglycerides?
Lower their triglycerides. Sorry, I'm losing it. Yep. Okay. So triglycerides is another fat. We all understand about cholesterol. We all understand that triglyceride is another fat in the blood. I also talk about a thing called HDL, and LDL, the good and the bad cholesterol. So it's important to have that conversation with patients and tell them the targets we're going for. Triglycerides, the usual thing, is often related to fat in your diet, but there's one thing that will really put triglycerides up, and we see it in men all the time, and it's a thing called alcohol. So, to reduce your triglycerides, you need to cut down your saturated fats in your diet, but very important, cut down on your alcohol. And the two of them will certainly bring the level down. We do have medication to do it, but, at the end of the day, it's not all about tablets. And this is where we run into trouble with diabetes, because it often involves a lot of medication to treat their blood glucose, their lipids and their sugar. So adding another tablet's not going to do it. So that's why we really need to harness the positive effects of weight loss. And if we can get the weight down, we can decrease our saturated fats and our alcohol. They all work hand in hand together. The triglyceride will come down automatically. We all worry about cholesterol. We think that's the biggest risk factor for vascular disease. But triglycerides is also an independent risk factor as well.
Okay. So you've actually sort of touched on the first part of Jason's question, which was that he's saying his doctor wants to put him on blood pressure medication. Is there a way that he can do that naturally so that he doesn't need to go on on that medication?
Depends how high it is, but yeah, look, it's always worthwhile try. If it's only mildly elevated, we still have this probably cutoff mark of 140 on 90. So blood pressure of 140 on 90. We need to step in and do some treatment. I'm a big believer in cutting down salt, sodium in your diet. I'm a big believer in exercise. If you do both of those things, if you've got mild elevation in blood pressure, you can bring it down. The reality is, however, that if your blood pressure is moderate to high, or moderate to very high, the reality is we need blood pressure medication. And these days it's not that bad, because we often have 1, 2, 3 drugs rolled into one tablet. So it needn't be that hard. My father had hypertension. I'll be 65 this year. I've got hypertension. I'm on treatment for high blood pressure and cholesterol, and I just suck it up. I try and be good dietary-wise, do a bit of exercise when I can. So, it's not all just about medications, but the most important thing, and we've got good data, the old UK PDS type 2 diabetes data that tells us the most important thing to control in type 2 diabetes is not necessarily blood glucose, but blood pressure. So it's very important to stop you from getting a heart attack or a stroke or even dropping dead, to get that blood pressure controlled.
Yeah. So I love this conversation because this is giving people ideas of conversations that they can then have with their GP later on.
I have these conversations day in, day out.
Yeah, and also, I guess people, having these conversations, as we said, and normalizing them so that people don't sort of get a little bit stressed or freaked out if suddenly we're talking blood pressure, but hang on, my blood pressure is okay, isn't it? But talking about it in a way that, yes, it is, but this is what we're talking about, for what might happen, or actually now it's time that we do something a little bit more proactive, and so that people understand that it's not that they've been bad, it's not that they're being told off, it's just we can do something about it, so let's have a chat about it. And I think that's really, really important.
I know as a GP, I always come up against brick walls if I play the blame game. Playing the blame game doesn't work. It's not your fault, it's there's lots of reasons for it, your family history. We do know too that type 2 diabetes, it runs in families. So if your dad or an auntie or an uncle or your mum had it, there's a chance that you will get it. And I see this particularly in the Arabic population in this area. But they usually come in because they know their parents have got it. And they say, I want a checkup. Can you do a blood sugar? I need to check it out. I need to know if I'm going to get it because, mum's got some problems with her eyes. Our dad had a heart attack when he's 60. I'm 50. I don't want to have a heart attack at 60. So all these things are making patients proactive to, perhaps come in and have checkups. And I think it's a good thing because at the end of the day, why do we treat type 2 diabetes? We're trying to prevent the vascular complications. We don't want to go blind. We don't want to have kidney failure. We don't want to lose a feeling in our feet and hands. We don't want to have a heart attack. We don't want to have a stroke. And more importantly, we want to live longer.
Absolutely. And John, can I just say, I live with type 1 diabetes, and unfortunately, not all health professionals have that very non-judgmental, truly, wanting to, so that people don't feel that they're to blame. Not that unfortunately isn't everybody's experience. So I can understand why you're running a very busy practice, because I would certainly want to be seeing, you're exactly the sort of health professional that I know that I want to see. We hear about people walking out of their appointments feeling quite, I guess, disempowered, and that's not going to make somebody want to come back next time, is it?
No. We've got to sort of normalise the situation, make them feel comfortable, make suggestions which they may or may not take. We can't force anyone to do anything, but we can always make it a little bit easier for them to do it, so that maybe it's not that hard. Yeah,
absolutely. So we touched on before about seeking mental health support, but could we just talk about what is available if somebody comes in and they're really struggling with their diabetes management, but you think perhaps that them seeing a psychologist or a counsellor might be a good idea. What's available to people? Is it a matter of getting a referral from you, or where do people go from there?
Yeah, look, there's no doubt about it. We're very much aware. I sit on the specific interest group with the College of GPs, so we do guidelines. We revamp the guidelines for diabetes every 2 years, and there's no doubt that you have to sort of delve into that question around mental health, because we know, they're just so comorbid, like heart disease, diabetes, depression, anxiety. We're very lucky in this country. We have very good medications, but more importantly, we have very good access in terms of mental health plans, getting patients to see psychologists, particularly when they're struggling and they're not able to get where they want to get, and they just sort of need that encouragement. Some of that comes from me, like I think we talk about cognitive behaviour therapy. As GPs, I think we practice that all the time in our consultations, but sometimes we need to sort of widen it and take it a bit further. And that's where I have a psychologist in the building upstairs. So, you know, if I think I'm struggling, or more importantly, if I think the patient's struggling, I'll give them a referral, do a mental health plan, and get them to see the psychologist. And it's all a matter of working together. One of the important things with type 2 diabetes is team care. You know, it's about seeing the doctor, but it's often about seeing the practice nurse, the diabetes educator, the podiatrist, the physio, optometrist, and very, very importantly, the psychologist when needs be.
Wonderful. We're about to wrap up. So if anybody has a last question, you better get it in quickly, because otherwise we'll miss out. But thank you to everybody who has participated. Have you got some parting words of wisdom, John? Say somebody comes in and they're newly diagnosed. You just told somebody that they're diagnosed with type 2 diabetes. Tell us about how that conversation goes. How do you give them hope, and, you know, so that they understand that what's going to happen next?
You talk about the positives. You talk about, in a brief consultation, just what the disease is, what it means. I talk about goals. People often worry about going onto insulin, and I'll say to them, look, diabetes, very importantly, I think we need to do this from the outset, is that it's a progressive disease. You might sort of stave it off for a while with diet and exercise, but you're ultimately going to need to go into medications. These days we have wonderful oral medications, and now even injectable medications that can actually prevent you from having heart attacks and strokes. There's no doubt that, you know, we need to get some weight off you. That's not always the case, but usually is the case. And the way we're going to do that is we're going to get you to have a look at your diet. I'm going to get you to bring in a diet diary, and we'll talk about it. Do you exercise? Have you exercised before? Yeah, get an exercise history. Let's sort of see where we can go here to sort of try and get you back on track, so that you're in control, like a lot of my other patients. Again, normalising it, saying, look, you're not the only one. Okay, yeah, you might need to go on injectables and insulin someday, but the longer we can prevent you from doing that, maybe that's the best way to go. So let's work together, and between us, we'll end up with a good outcome. I don't want you to go blind. I don't want you to have kidney failure. I don't want you to have a heart attack or a stroke. I want you to hang around for a bit longer. So let's work together, because it's all about team care that's going to allow us to get to the goals we want to.
Absolutely. Well, there's a great psychologist in the US called Bill Polonsky, and Bill says everybody wants to be healthy. I know all about the Polonsky data. Love Bill to pieces, and I love it when he starts from a place of everybody wants to be healthy, and I love that, because then it's how can we help you to be as healthy, live your best life with diabetes. So, John, thank you so much for joining us today. Thank you to everybody who's along. We've had some great questions, and I'm so thrilled that we're talking men's health, because we don't do that enough. George says, love yourself. Love that, George. I think that's really important as well.
Exactly.
But thank you, John. I really appreciate you being so wonderfully candid and so non-judgmental. We love that. Thank you very, very much.
My pleasure.
All right. Okay. Thank you, everybody.
Thank you.